Good afternoon, everyone, and welcome to today's Lunch and Learn webinar for the Iowa Pediatric Mental Health Collaborative, Substance Use in Adolescents, Assessment and Intervention, presented by Dr. Nesrin Abu Ata. My name is Kathy Dixon, and I'll be moderating the session today. I'll cover a few housekeeping items before we get started. The webinar will be recorded and made available for viewing on our YouTube channel. The link will be shared in the follow-up email after the session. Following the presentation, we'll have time for questions. Please use the Q&A feature in the webinar toolbar to submit your questions, and we'll cover as many as time allows. I'll be uploading instructions for how to claim CE credit that will be available in the chat section for you to download, and I will also send this in the follow-up email after the session. So without further delay, it's my pleasure to introduce our presenter today, Dr. Abu Ata. Dr. Nesrin Abu Ata is a board-certified family medicine physician, adult psychiatrist who is also board-certified in addiction medicine. She did her residency training at the University of Iowa in both family medicine and psychiatry. Her training in integrative psychiatry comes from the renowned Integrative Psychiatry Institute. She also holds further training from the Harvard Program for Refugee Trauma and is a 200-hour certified yoga instructor. Dr. Abu Ata has practiced in many clinical settings and has worked with people of all walks of life. She has worked in substance use with adolescents in the outpatient and residential settings, along with their families. Dr. Abu Ata is the founder of Mind Alchemy Clinic, where she sees patients providing psychotherapy, medication management, and ketamine-assisted psychotherapy. She's based in Sioux City, Iowa, and sees patients in person and virtually. So welcome, Dr. Abu Ata.
Thank you. Thank you guys for joining us. And I think this is an important topic right now to talk about, especially with the surge and the increase in substance use in adolescents. And just let you know, I have no disclosures at all. And today we'll be covering the topics of what does it look like when an adolescent struggles with substance use, what kind of features to be looking for, and then some screening tools and some brief interventions that we can do, including motivational sort of behavioral change interventions. And throughout this whole talk, I'm going to be giving you a sense of a picture in order for you to be able to navigate and see where, when you're working with an adolescent, where they might be falling, if it's a kind of a mild, moderate, or severe range, because it helps to engage the severity and your level of intervention once you have a better picture of where the adolescent falls on the spectrum. So I'm going to give you these three cases just to keep in the back of your mind, because I want you to always keep thinking, is it mild, moderate, or severe kind of range when you're working with adolescent? The first case, John, 14-year-old, comes in for his annual exam, just has acne, no other problems or complaints, just had ear infection as a kid, no hospitalization, not on any medications, a family history, nothing for mental health concerns, no stressors at home or at school, and he says he doesn't use any substances. So that's an annual exam for this 14-year-old. Then you have a 16-year-old woman or young lady. She comes in for the annual exam. She plays tennis, just has asthma, never been in the hospital. She doesn't have any psych history. Her sister has depression. The parents are divorced. She lives with her mom, but she tells you in the visit that she gets stressed at school, but she can handle things. The other day, her dad and her were at a party, and then her dad drove. The dad was intoxicated. That's the only thing she tells you in the visit that's related to any substance use, nothing else. And then the third case, Katie, she's 17, comes in for emergency contraception. She got drunk at a party, had sex with a new partner, doesn't remember if she used condoms. In the past, she used Plan B. And she's otherwise healthy. She's going to senior, going to college, lives with the parents, no mood symptoms. But she drinks alcohol, and she had tried pot. She tells you she drinks to relax, to forget her problems, and that she got in trouble because of drinking alcohol. So that's our third case. So keep these three kids or three adolescents in mind as we go through the level of severity and what things to look for in the adolescents when they come see you. So just the bigger picture, a lot of times people think substance use starts in adults, but really it starts actually in adolescents. A lot of times when they're coming into the clinic at the age of 14, 15, that's when the substance use starts. And then later, by the age of 24, so young adulthood, actually a lot more substance use also shows up. So this is a spectrum, and it's starting in the middle school age group when they're coming CU high school. A lot of times there's also co-occurring. The substance use is not happening in a vacuum. They're having depression, they're having anxiety, and along with that, they're beginning to use substances. And these adolescents are at increased risk for poor health outcome because they have high risk behavior, high risk substance use. So they would use a substance, and then they can get into car accidents, they can get injuring themselves, they can get with HIV, STDs, all sorts of things with their substance use. It puts them at high risk conditions because of the high risk behavior. So keeping that in mind, depending on the context that you're seeing them in. In general, why are they using? Because it feels good, or it feels good to get high, or they have some sort of emotional pain, or they need help with sleeping, or they want to fit in, or there's peer pressure. So there's all sorts of reasons why the adolescents are using the substances, and it's not just one size fits all, but just bear that in mind when you are meeting with them and bringing the sort of curiosity to ask, and not so much judgment when you're meeting with them. More numbers for you. 14% of kids report misusing prescription opioids. So you have your athletes who's playing sports, they injured themselves, they got prescribed an opioid, and 14% of them misuse it, or they got it from a friend who got it prescribed for them. 15% of high school students report actually having ever tried some sort of a drug or injection drug too. That's 15%. That's not a low number. When patients are using opioids, it's linked to higher sexual risk behavior too. And kids that are using more of the prescription drugs are more likely to actually have been victims of physical or sexual dating violence. So bear that in mind when you're meeting with adolescents and they mention that they use a substance. Going back to that curiosity of asking and keeping in the back of your mind, what else happened? They might not be telling you there was physical or sexual violence, but just to kind of keep that in the back of your mind to create space for them. That way, if they bring up something, you might be able to meet them there too. So again, as you're listening to me, I want you to think of the criteria. I want you to think where we're at with a mild, moderate, or severe. With the substance use diagnosis now in the DSM-5, really the main important thing is that the substance causes continued negative effects. So if they're not reporting negative effects, it doesn't mean it's not affecting them. They just might not be reporting it to you. So keep that in mind. So always track what's going on with them socially, in school, in the grades, interpersonally, attendance, because all that can cue you in on the negative effects of the substance. That's really your first kind of clue. And then once that gets triggered in your system, in your mind, okay, there are negative effects, there's something going on, then you want to start thinking, where are we at mild, moderate, or severe level of substance use? Because that affects your level of intervention and level of acuity. These negative impacts that I'm telling you about, and we'll go on next in the second slide or next slide, what it does is that it affects in different sort of categories. So the physical dependence, they physically get dependent on it, they start having social problems, and they start doing risky things. So a kid that's missing school, a kid whose grades are dropping, a kid who's getting in trouble with the teachers, with the classmates, and then taking it to the level of getting in legal trouble. These are the social problems that are arising from the substance use. And then also risky use. Are they coming in like the third adolescent that we had with having unprotected sex? Risky use. Are they driving while intoxicated? Just keep your ears out when you're hearing behaviors that are risky, because that can cue you in there's substance use there, and now it's affecting them negatively too. So the severity, and we'll go through the criteria. But if they only have 2 or 3 criteria, that means it's mild. If it's 4 to 5 symptoms, it's moderate, and if it's 6 or more, it's severe. So if a kid tells you, oh, I smoked pot one time with a friend of mine at a party, and they're not reporting you to anything else, and it was just a one-time thing that they used, no impairment in school, no impairment in relationships, grades, legal trouble, that just puts them on the radar for you that there's some risk going on, but they're not hitting the mild, moderate, or severe. So always keep that in mind when you are scanning where they're at with the criteria. This is just the list of the substance use disorder criteria. I'm not going to go over it. You probably have come across it in the DSM-5. Okay. I like this graph because it's another way of what I'm trying to capture with you of thinking where does the person fall on the spectrum of addiction? Where does adolescent fall? So if there's risky substance use, like I told you, I tried pot one time. My friend gave me a beer to drink one time and that was it, or something like that. They're at the risky substance use. It just very becoming aware, giving education, but this is just risky substance use. It's not meeting the level of the substance use disorder. So you're not hearing any impairments at all. Once you start hearing there's some impairment in social, grades, relationships, health risks, you start thinking, okay, how many symptoms do we have? Is it 2 or 3, 4 to 5, 5 to 6? Because once you're hitting more of that 5 to 6 and severe, you're heading more towards the addiction sort of level of use. You wouldn't think that 14 or 15-year-old would be at the addiction level, but it also depends when they started, depends on the biopsychosocial things going on for them. But for the time they're meeting with you, whether it be in school or at the clinic level, they're usually probably here at the risky substance use or substance use disorder, mild, moderate, maybe beginning of severe. Just keeping that in mind. Again, another way of painting pictures for these kids that are at risk. If there is history of family substance use, if parents are okay with the kids smoking. I've had parents where they tell me, hey, I smoke pot all the time. I'm going to have my kid around me. We smoke together. It's our bonding time. That really affects the kid and sends a message to the adolescent. It's okay to smoke. It's not a big deal. My parent, who I look up to, who is my authority figure, who models for me how to behave, they're smoking, so it's okay that I'm smoking. Other risk factors, the parents are not monitoring. If they're not keeping track of where their kid is at, they don't know what they're up to. Another risk factor too, if the kid tells you they're not connected in school, they're getting bullied, doesn't have friends in school, doesn't have a group that they belong to, they're more likely to want to use to fit in, to belong, to feel better too. Having low academic achievements also is connected to more substance use or risk for it too, because of not feeling good about oneself, wanting to escape the stress. So then they end up using more. Any history of childhood sexual abuse or mental health issues too. So screening for the co-occurring with depression, with anxiety, because they're more likely to have risk and want to try substances to make themselves feel better too. I like this graph because it shows about the connection between drug use and then how kids do with academics. So the adolescents that the grades were A's, they were less likely, or there were 24% chance for them to be using a substance. Kids who had D's and F's grades, they had a 25% chance or 66% chance of using substances. So that's pretty significant between 66% of having tried and used versus 24% with the grades. Kids that have A's in general are more driven. They have more sense of positive about who they are, where they belong, where they fit in. They have more drive, more involvement with parents. So it's a different kind of population than kids that might have D's and F's too. The other thing too, with the kids that have D's and F's, they might be struggling academically. Their IQ might be lower. They might have been children of parents who use substances, and their parent or their mom might have used substances while she was pregnant with them. So they might already struggle with maybe untreated ADHD, lower IQ. So they're already in that kind of range of a D's and F's. And so they're more likely to also want to try use a substance. This statistic was also interesting that 3% of US high school students with A's tried marijuana versus the kids with the D's and F's, actually 25% of them tried marijuana too. This is about prescription drugs. Again, similarly, it's a difference of, if you think about it, threefolds. Kids with the D's and F's, they tried prescription drugs that were not prescribed to them. And then the adolescents with A's, only 11% of them tried it. This is about heroin. It's a scary statistic to think even 10% of the kids tried heroin too. You see. This is just a little nugget, again, for you to screen where the parents are at with the kids, because like I said before, if the parents are engaged and are supportive, the kids are less likely to want to be using the substances. But if the parents are not engaged, they're not monitoring, they're not keeping track of their at, they're more likely to be using substances. Something that is interesting to keep in mind is that these adolescent brains are not the same as adults. Their brains are continuously changing and growing, and this is the time where they want to explore and take risks because they're building their sense of identity and who they are. So along with the taking risks and trying things, that's when they also might try cannabis or alcohol, depending on who's around them. Or now there is fentanyl, and actually meth is becoming more available, more accessible to these teenagers. So what might sound like it's a great idea and a risk taking in their brain might turn into more than just a one-time trial. So the question to always work with the parents is, when you meet with the parents, do you know where your kid are at? Do you know what they're doing? Do you know who they are with? Check in with them. I have parents that do the Find Me app, so you're able always to track the kids to know, or the adolescents to know where they are at too. And when the adolescents are coming to see the provider, it is really important that they have the one-on-one visit with the provider. A lot of times the parents might want to stay, but really once they start in middle school, I like to have the one-on-one time with the adolescent. It also starts to give them a sense of their own independence, their own sort of sovereignty, and their own sense of, okay, I can start to learn about myself and my own decisions and not have my parent tell me what to do and to decide for me. So in a way, when they're meeting with you one-on-one, you're starting to promote that sort of sense of um, sovereignty within themselves that they are already coming into as teenagers, part of the individuation that they become. So it's important that we do some sort of interventions when they come or screening with us. And what I'm going to cover today is what they call the craft screening, but there's also spirit screening. And my intention when you were talking about the craft screening is for you to start to know how to ask the questions with the adolescents when you meet with them, depending on your context, because you might be a teacher in the school or you might be early intervention in school versus if you're in the clinic. But you can take these questions and work with them even outside the structure of the clinical intervention with the adolescents when they come to you in the clinic. So what does CRAFT stand for? This is easy to remember. CRAFT. So C is for car, R is for relax, A, alone, F is for family and friends, and forgetting, and then getting in trouble. And we'll go through the questions and it will make more sense. There are 9 questions, but that's what the CRAFT stands for. And you can do the craft intervention in 2 ways. You can actually have the adolescent fill out the questionnaire, or you can also ask them to them. And some adolescents would rather be filling out the questionnaire. And some of them, if you're meeting with them one-on-one anyway, you might as well, and you have the good rapport with them, you can start asking them the question too. And the questions are the same, whether it be they're doing the questionnaire on their own or you're meeting with them one-on-one. And the most important thing are the first 3 questions because these are your screening questions. So, over the past 12 months, how many days did you drink more than a few sips of beer, wine, or any drink containing alcohol? So any drink. If they say 0, that lowers the risk. Now, the other question moving from alcohol is marijuana. Again, over the past 12 months, have you used any marijuana or any synthetic marijuana, K2 spice, or THC oil, or vaping? And you see how much they say. You might even ask them to what they think of as marijuana or what they mean by vaping because it's still THC, but kids or adolescents refer to it in different words too. And then you want to ask them, have you ever used anything else to get high? So any illegal drugs, prescription, over-the-counter medications, things that you can sniff or vape. Because sniffing actually is very common in adolescents. So they don't think of it as a substance per se, but they're getting high off of it. So these are our first 3 questions. If all are 0, then you're going to go only to question 5. If you've ever ridden in a car driven by somebody else who is high or under influence of a substance. But if they answer 1 in any of these boxes, they're already telling you, hey, there's some flag there that you need to screen more and assess further. So then the other question becomes, do you ever use alcohol or drugs to relax, to feel better about yourself, to fit in? And that goes back to that question of what I was mentioning before, that some adolescents already having depression, already having anxiety, already are stressed, and they want to feel better, and so they use a substance. Do you ever use alcohol or drugs while you are by yourself or alone? Because that increases the risk. It's one thing if they're using it with other friends, because if the friends are not around, they're not going to use it. Do you ever forget things you did while using alcohol or drugs? And then do you or your family ever tell you that you should cut down on your drinking or drug use? This is probably going to come back more from friends than family, but eventually the family might start noticing things too. And then the trouble part. Have you ever gotten into trouble while you were using alcohol or drugs? And that can be trouble with school, it can be trouble with skipping school, being late, turning in homework, or actually they might be they got involved with the law for breaking the law or stealing alcohol. A lot of times the shooters, the patients might steal too from the store. Depending on how they score, you're also going to be adding it up because then you can actually discuss with them and talk with them their likelihood of, depending on their score, their likelihood of actually having an actual substance use disorder. Because this craft is actually a screening. It's not diagnostic, but it's to help you figure out, okay, are we in the risky use or is there something more? And now I have to do further assessment. So if a kid or an adolescent only scores 1, so let's just say they said here, I drink more than a few sips of beer, and that's it, nothing else, then that puts them at actually even 32% of meeting criteria for substance use disorder. If they score 2, that's already 64%, which is high. And so 2 can be here. If they've used alcohol and then pot, that's already here too. Now, once they score 3 and above, their risk really jumps of having an actual substance use disorder. And that's when you want to start to think, okay, I need more interventions. I need to refer. We need to do more closer follow-up. So now it becomes, once you've screened them again, I'm going back to these, I wish I could have different pages, but I don't. So once you've screened them again, and they've told you that, they've scored positive on some of the crafts here already, if they're scoring a bunch on the craft, or if they scored 3 here, they're already positive, and now we need some sort of intervention at a primary care level sort of setting. So now what do you do? Because the adolescent filled it out. The parent is waiting in the outside room. And so you want to review it with them and you want to have a conversation with them. Can you tell me more? Tell me about when you rode in the car and your friend was, what was going on with your friend? You also want to ask it in a way when you're reviewing it about asking about the friends, because it might feel like you are alienating them or judging them if you're asking directly about their direct substance use at the beginning. So you might want to ask about the friends, the connections that they're with, how they use, how that's impacting the friends, and then get to asking them more about themselves, their use, how it's impacting them, what was going on when they were using. So just going the questionnaire with them in a non-judgmental, neutral way to get them to open up too. And this might not happen the first visit. It might take them a little bit of time. But also some of the adolescents, they might already know something is up, or they might not feel good about it, or they might have shame about it. They might want to talk to somebody. So holding that stance of non-judgmental curiosity, trying to understand more, is really important. The next thing after you've reviewed all the questions with them is you give your recommendations. This is different. When we are working with adults, we're engaging more in a sort of engaging their sense of what they know, what they want to do. This is also similar with the adolescents, but still as the provider or as the teacher or as the authority figure, you share with them what you recommend. You share with them what you see, because you never know if they know how much you know about it, them harming them or not. So when I have adolescents that report they're using, we go over their intake, how they filled it. I tell them in just an educational way, your brain is growing. It's not fully grown until you're 25. And so any substance use that you're doing now really impacts you a lot more now compared to later with your developing brain. It can prevent you reaching from your full potential. I also discuss with them that it can affect your memory and learning, and how that's when we talk about how grades have been. How they've been able to turn things in, showing up on time, and discuss the impact of the substance on their learning and memory. And then we talk about also that substance use can put them in danger and embarrassing situations. And that's where they might tell me more information actually, because they might not have mentioned this in the reviewing it, but this is where I might ask them, have you noticed the substance use? Has it put you in embarrassing situations? Or your friends, has it put your friends in embarrassing situations? Again, with the developing brain of teenage or adolescents, you want to always bring in the sense of the friendships, how it's impacting others, because this is the time when they're building their identity in the context of the relationships with the other adolescents and friends with them too. So after we talk about the harms of using the substance, then I talk with them about the risk of the substance use. And I can't stress this enough. About driving while intoxicated, the impact that it can have on driving while intoxicated, the motor vehicle crashes. Sometimes it might seem like when you're meeting with the adolescents that the message is not coming across or coming through, but it actually does. I've been surprised. I've had adolescents where they were, I had one where he drank alcohol, his friends drank alcohol, but they had enough sense to order an Uber. And the adolescent was about 16 years old. Once he got home, he just crashed. He didn't remember anything else. And of course, the parents were upset the next day and how upset about why he drank and how he put himself at other kinds of risk. But I really stressed in the visit when they came to see me the next day is you had enough sense about you not to drive the car. You had enough sense about you to order an Uber, and that saved your life and your friend's life. So that's why for me, I can't stress enough the importance of the risk counseling, risk and harm reduction. Whether it be have somebody that can drive you, whether it be have somebody who is sober with you. It doesn't mean we're promoting adolescents or underage using substances, but from a harm reduction standpoint, if they're going to be using it, providing them and educating them about how to minimize the harm too. So after we talk about the risk counseling for them, I also talk with them about what do they hope for themselves? What do they want to commit to in the future? So they can keep that in mind when they're in dangerous situations. So I committed to my family. I committed to my guardians. I told my friends I'm going to be better. I told my friends I'm going to be sober. This helps with the risk counseling because they're keeping in mind the positive commitments that they made to themselves or somebody else too. Some providers have the patients do what we call a contract for life. I'll include the sample in the next slide. I like the idea about the contract for life because it starts to orient the adolescent to, I can commit to something, I matter, and now I'm becoming an adult. There's a sense of adulthood where I signed a contract. Okay, I'm going to take accountability. I said I'm going to do this. This is what we talked about. So this whole idea of a contract for life is not to shame the person, but it's more to teach them accountability and being responsible for themselves and their choices, which again goes back to risk counseling of how do we minimize the risk? How do we minimize the harm in these sorts of conversations with the adolescents? Now, the fourth one is asking the adolescent directly, how would they respond to certain things? So how does substance use help you? What do you like about it? What do you not like about it? How does this benefit you? So really asking them things that help them focus on themselves so then they can get motivated and then they can stay committed to why they don't want to use substances. And it can be very, in adolescent kind of brain, for example, with smoking, we talk about what don't you like about smoking? Oh, I don't like smoking because my hair starts to smell. Oh, I don't like smoking because my hands, the tar on my hands. Or I don't like using a substance because of the way I look. So it's interesting to ask them how would it benefit you not to use it versus how is it harming you when you're using it? And them coming up with their own reasons. Because that, again, it's something from themselves that they can be motivated by and stick by too. Now, the number 5, which is reinforcing self-efficacy, is really, really important. This is the time when the adolescents are building their own sense of self-identity. Along with comes the substance use or the trying it. They're still trying to figure out who they are. They're still trying to figure out, can I trust myself? How can I believe in myself? And so you advocating and you're reinforcing that I believe that you can take the steps that you need in order to stay sober, that's huge. It might not seem like it's landing for them, But the sense of connection to a provider or an adult that is safe and that believes in them and encourages them and does not judge them is huge, because then the next time when they come back, you'll follow up on it and you ask where they're at with the substance, and you listen. And you listen to these, small change talks. You listen to what did they accomplish that was positive, that was reinforced the self-efficacy. So like I said, the adolescent that I had that even while inebriated under alcohol, he had enough sense not to drive. That's huge. And even now when I meet with him, I always bring that up because there's some wisdom in him that he understood I'm not going to do that. And that's a choice that he made for himself, and that's that sense of self-efficacy that want to help build in the adolescence. So the contract for life, it's Students Against Destructive Decisions that this was created by. And it's an agreement that the teen doesn't accept a ride from a driver who's been drinking alcohol or using other substances. And if they sign it, again, it shows or gets them think, okay, I talked to somebody else. I told the adult I'm not going to do it. I promised. And that will pop in their mind when this comes up. So starting the conversation, again, you're always planting seeds when you're meeting with the adolescents. This is just a sample of what it looks like. The adolescent saying, I recognize that there are many potentially destructive decisions I face every day, and I commit that I'll do everything in my power to avoid making decisions that will jeopardize my health, my safety, overall well-being, or trust in me. And I understand that dangers associated with the use of alcohol and drugs and the destructive behaviors often associated with the impairment. And I like this part, that I pledge my best effort to remain free from alcohol and drugs, and I agree that I'll never drive under the influence. And I agree that I'll never ride with an impaired driver, and I agree that I will always wear a seatbelt. And I agree to call you if I'm ever in a situation that threatens my safety, and to communicate regularly about my needs. So again, this is setting the intention, planting the seeds for these adolescents. So this is not about judging somebody. This is not about saying you failed. This is not about discharging somebody if they're not doing it, but this is teaching them, we talked about this. I said I'm going to follow through. I didn't. Okay, so now what do we do? Let's talk about it. What happened? What can we do differently? What do we learn from it? It's promoting that, again, sense of self-efficacy, promoting you learning about yourself and how to ask for help. Because if the adolescent is not able to ask for help, and if they're not able to understand what accountability is, then when they're in the middle of a high episode of using substances, they're not going to even think to call somebody. They're not going to even think to talk about it. They're going to disconnect and dissociate too. So just use these things as what I think of as conversation starters. You're building the relationship with the adolescent over time. They're coming back and seeing you for annual exams. They're coming back to see you for their asthma medication refills, for their acne. So this is a relationship that's building over time. This is another way of working or understanding the craft again. So let me see if I can show you. Wish I could have multiple faces, but I don't. So again, going over it again. If they haven't used anything here and it's 0, this is, you just give general education. Substances are not good for you. Substances affect your brain, just a general kind of education. So they're really kind of a low risk. Now, the medium part is if they told you no, they haven't used anything in the past 12 months, but then when you ask about the car question, have you ever ridden in a car driven by someone, including yourself, who was high or had been using alcohol or drugs, then that puts them at the medium risk, because they've ridden with somebody who was drinking. That puts them at risk. So that puts them in that medium range. Another way that puts them in the medium range is if they tell you, like I mentioned before, yeah, I drank alcohol, I tried pot, and then they already probably did one of these. But really, if these are 2 that are positive, they're already in the medium, you need to have more of a focused intervention with them. The high score is if they scored here and then they scored here. So that's higher risk of developing a substance use too. And we'll go over how you can intervene with them or what you need to do depending on the level. So I'm going to give you an example of somebody who, the first kid that we talked about, that didn't, let's see, that didn't use, didn't have any stressors. So the way you interview, the way you're talking with the child, the adolescent, is you're going to just say, thank you for talking to me about it. Thank you for completing this paperwork. I've looked at the results. Is it okay if I talk to you about it? It's also important to them with this, it's important that you talk about confidentiality. That anything you tell me is kept confidential unless there is a risk for your safety or someone else's safety. And let's just say the patient tells you they're suicidal or there's a risk and you're going to tell the parents. You also have to tell the adolescent, I'm going to let you know that I'm going to tell your parents and we're all going to figure out what to do. So it's really important that you set that kind of foundation when you're going over the questionnaires with them because they have to feel safe. They have to feel like they're heard and that they can trust you. Because if that's not established, then anything else to intervene here or say is not going to really be trusted by them too. So this is a child, again, that is in a low risk. They didn't really score anything on it. So you're going to be, again, affirming that they're making good choices. So I'm glad you're not drinking. I'm glad you're not using drugs. That's a great choice for your decision, for your health. And if it changes, I really want you to tell me because I'm here to help you stay healthy. So that's the R part. Now, recommendation, again, this is what I talked about before. As the authority figure, as the teacher, as the provider, you want to tell them your recommendations. You don't want to shy away and not take the lead on it by letting them know the information that we talked about earlier. That substance use in general harms the brain. It affects learning. It puts people in situations at risk or danger or worse. And they might listen to you and tell you, oh, this doesn't affect me. True. And I'm not using anything true. But I preface it by saying, I'm just letting you know because your friends may be doing that and they might not know. Your friends may need direction and they're going to trust you and look up to you. So that even helps them get a sense of where they're at with their friends group when you're telling them, this might not be affecting you related to you, but it's important for you to know because your friends might be in trouble, your friends might be using, and they don't know that it's affecting them. That if anybody asks you, feel free to share, this harms my brain. The brain is not grown. Wait till I'm 25 till I use a substance just to give my brain the break to learn too. And then, as I mentioned before, you're going to talk about risk reduction, harm reduction, risk counseling. So if somebody is using, have a car ride. It's more common. I'm a bit surprised at adolescents because a lot of them know about Narcan. And Narcan now in Iowa, you can get it over the counter. You don't need a prescription. I think a year or two ago you had to get a prescription and now you don't. So I have been surprised by adolescents volunteering to me the information that their friends have Narcan on them. And so when they tell me that, I just say it's great actually for harm reduction. Somehow they know about it. Somehow they buy it for the harm reduction for protection. And this is going over the response, just to give you kind of samples of how to ask them. What would you say if someone asked you why you don't use marijuana? Because we're talking about a kid who's not using, and there might be peer pressure, and see what they say why they don't use it. Might be I'm playing sports. I want to keep up my grades. I want to stay out of legal problems. My parents don't support it. Just get curious and ask them why. Then why would they tell somebody? That way they don't get to be pressured into using it too. And again, going back to the reinforcing the self-efficacy, you're stressing again to them. You have so much promise. There's so much future for you. And I wouldn't want to see any substances affecting you too. And that's why I also ask, what do you want to see for yourself in the future? What are your hopes? What are your dreams? It's important to be future-minded, future thinking too, because sometimes some of the kids, unfortunately, depending on their home environments, they're not seeing the future because they're very busy trying to survive day to day. So that message from you that says you have a great future, I see so much potential for you, is so important. I can't stress that enough. I have another way of, or a few more kind of questions or interventions that you can do with adolescents. And one of them is the 5 A's for change. So again, asking, this is about tobacco. Tobacco is one of the hardest substances for adolescents to quit using. It's very, very addictive. And so I would start, if I have an adolescent that's smoking and they say they're using tobacco, I would ask, what exactly are they using? How much are they using? Do they feel like they have to use it in the morning? Is it just a vape that they get from a friend here and there? I want to know how they have access to it too. Do their parents know? And then we talk about advising them. So we want to advise them about the effects of it and how it affects them. And asking them also how quitting is going to help them too, or what they're bothered by it, what they're using. And like I mentioned, it can be something as simple as I smell like tobacco and I don't like that. Or it can be actually fear of quitting smoking because they say if I quit smoking, I'm going to gain weight. So it's important to understand the benefits from it, the risks they perform, the harms that they perceive. You want to also assess their level of dependence and willingness to make the commitment. Again, it depends on how bothered they are by their smoking, by the judgment from other people. Are they in trouble? Are they not in trouble? And so then you can also talk with them about resources to quit smoking too, and support without judgment. And then you want to have follow up with them. You don't want to just have that visit. So if it was an annual exam, you'd be seeing them once a year. But if you did this intervention for smoking cessation, you want to see them in a month or two, just to keep the conversation going. And you can use it to start building the rapport and the relationship too, and their sense of self in an open way, non-judgmental. This also is a different way, or the 5 R's for change, to open the door, open the conversation with these adolescents when you're beginning the intervention is, again, you want to ask them, why, how is this relevant to them? Why would they want to quit? Why are they bothered by it? You want to, again, ask them, what do they know what the risks are? Do they know how they're going to get impacted by it if they continue to use it? Maybe other friends have been impacted by it. Ask them if there are other friends that have gone to treatment. Just kind of feel out the environments they're in, the friendships they're in, what they're aware of, what they've heard of, because that can help redirect them to gauge what the risks are too. Because a lot of times adolescents are watching others and how they're impacted, but they're not connecting the dots that it's relevant to them. So when you start asking, okay, how has it affected other people in your class? How do you think that can affect you, their behavior? Then it makes it, the risk becomes more relevant and closer to them rather than something happening somewhere outside. You also want to ask them about the rewards, right? How is it going to help you if you quit smoking? How is it going to help you if you quit smoking pot? And then you want to also understand what are the roadblocks to quitting. And that's where the conversation can be, when I use pot, it helps me concentrate and it helps me relax. Okay, now we have something to talk about. Relax from what? What do you get anxious about? And now you start to even screen more. Is there social anxiety? And that's why they're using pot to help them in order to avoid the social anxiety that comes up in school. Or when they say it helps me relax and concentrate at school, now we can start screening for, is there ADHD? Because many kids are using pot in order to self-medicate either for anxiety or for ADHD. Or they might tell you, I smoke because I can't sleep and I have a lot of bad memories. Okay, so is there PTSD there? Is there trauma that's ongoing that they didn't talk to you about, but the substance use and talking about it can be a doorway to start talking about what's hard about the sleep. What are you hypervigilant about? Should we see a therapist to help you with the anxiety? Or even with the social anxiety, what can open the door and start talking about what skills do you have? How do you cope with the anxiety? What coping skills are you learning? They might not have any. Smoking or using a substance might be their only coping skill to help with their mood. So that's where you can engage with them. Okay, I have some ideas that I can tell you of how to help. Or would you want to talk to somebody that has, again, more time, like with the counselor when they meet, that they can help you have more skills? And you know what? If you learn these skills, it's going to help you, but you can also use it to help a friend of yours because a lot of these adolescents, and in general, with the way their progress is and their growth at this stage, they're very much oriented towards other people and their friends in the community. I can't tell you how many adolescents would tell me, I was on the phone texting my friend. My friend was having a hard time. My friend was anxious. My friend was depressed, and I wanted to help them. And if they tell me that, that's a great way for me to start teaching them skills, coping skills. I'm like, you might feel like you're okay and you can help self-soothe, but your friend doesn't know. So you can share that with them so that they can share with their friends too. And repetition, repetition, repetition. It might not seem like the adolescents are listening to you when you're talking, but they are actually listening and they're taking in the information. And then it might come back later and it might come up again later when you meet with them, but always come at it from a place of neutrality, a place of a neutral stance and being curious and asking because they're continuously growing. They're putting the pieces together of who they are and their identity within themselves and also within the community with the friends that they're making and the friends that they're leaving also too. It might feel like you're not making big waves, big changes, but it's with the adolescents, it's always planting small seeds and it goes a long ways later too. I see that we have questions. No, no questions. There were two things, I didn't put it on the slides, but I was going to also bring up for you guys. One of them is, and I mentioned it about the Narcan. So Narcan you had to have a prescription for it in the past, but now in Iowa, you don't have to have a prescription. And I always advise parents to have Narcan at hand on them just in general, because you never know if you need to use it or not. The adolescent might be vaping, and in the vape, it might not just be THC, it might not just be nicotine. Now, unfortunately, there's other opioids in it, so like fentanyl or the stronger one, which is carfentanil. And so it's good to have the Narcan on you. And I also advise to have more than one Narcan because sometimes you might need to use Narcan multiple times to reverse the effects too. So I think that's a good kind of preventive step um, to have on. That was one thing
Okay.
that I didn't have in the slides. Yeah, go ahead.
All right, thank you. We had some questions that came in during registration. We'll kind of start with those as we have questions coming in. Before that, I had a question on the craft. Is that a resource that's available online that providers can download, as well as kind of the instructions for how to
Yes.
review it? Okay. Okay. And then another question is, there's we hear a lot about vapes, and, one of the questions was, what are the drugs typically found in the vape pens?
Yeah, so the vape has THC, the marijuana, but it's a lot more concentrated. And so they're getting higher concentration of it. That would be one. And then it has the nicotine. It has also nicotine in it. But then now, as I mentioned before, it's starting to get mixed with other things like fentanyl, which is an opioid, and then a stronger opioid called carfentanil, and then also meth. So I've had patients that tell me, oh, it was just my friend's vape and I smoked it. And then I was very jittery and then I became very paranoid. It wasn't the same sort of only pot THC. And that's where I think it might have had meth, but we couldn't test for it. So, and that's why good point with education with the kids is that just because a friend offers you the vape saying it's just THC or just nicotine, that is not true. Be careful. Just putting in that seeds for awareness. So,
Thank you. Um, do you recommend CBD for patients who are struggling to come off of THC?
no, I don't. There are ways of helping. So I have two falls of approaching with using THC because many times the adolescents are self-medicating for something else. And so that's number one that I want to screen for is what else are we medicating? Social anxiety, ADHD, PTSD, major depressive disorder, because I would start treating that. It used to be that we only treat one condition, like only substance use, but now we treat both. So screen for comorbid mental health condition, start treating for the comorbid mental health condition that they're self-medicating for. That's the first arm of the mental health piece. And then in terms of helping them get off the THC, I wouldn't use CBD. There is a supplement called N-acetylcysteine, and that can help with the cravings from the THC. And so as we start that, then they can start cutting back on the THC, and the neck helps so they don't have the craving per se, that chemical sort of craving. But again, it doesn't treat the mental health condition, mainly for the cravings from THC. And it's something that you don't need prescriptions for. You can buy it off the counter. But that can be challenging because some patients want to use the insurance, but it's just over the counter. So
Okay, thank you. As adults, what are some warning signs that teens may be using? And I know you covered some of this during the talk, but are there, some things you want to add to that or highlight?
that's a great question because I know that adolescents want the privacy of their rooms and the kind of individuation idea, but in my book, they live under your roof. And so it's important that you also keep track of their room because some of these pens are hiding somewhere in the room too. And so I wouldn't, I would always keep track of the room, kind of, it's not clean, what else is in the room? That's number one. The other thing is grades starting to drop. interpersonal difficulties, missing school, getting irritated easily, not doing chores, a change in temperament, a change in relationships, any change from baseline or change in friends, to me, are signs to look more into it.
Okay, thank you. What are your recommendations for treating these patients for comorbidities like anxiety, depression, and ADHD? I've had other mental health providers refuse to treat patients if they are using drugs.
Yeah, that was the old school, is that they used to teach, oh, you need to treat the substance use only and then assess for the mental health condition. But the Addiction Society now talks about we need to treat both. We need to treat the mental health comorbid with the substance use. We can't just say you need to get off the substance and then we'll get to treating the mood. So if this is a primary care setting, you can start the treatment for the mental health. If you're assessing if there's depression, if there's anxiety, you can start treating it. That's where I would start. So I would have the primary care start treating the depression and the anxiety, but also prefacing it with talking with the adolescent that part of the anxiety might get exacerbated at the beginning because they're getting off the substance too. So it's continuous assessment for both the substance, the withdrawals from it, but then underlying mental health condition and treating both. And the primary care can start the treatment there, at least until they're able to get them in to see somebody else more specialized for that.
Okay, another question is, what is the dosing for NAC? And I'm not familiar with that.
Yeah, it's called,
NAC.
yeah, so it's N-acetylcysteine and it's a
Okay.
supplement. And it's interesting because we can use it for different things. Um, when people, for example, they overdose on acetaminophen, they can give them that. It helps with what they call the oxidation pathway in the brain chemistry. Um, so it's not created only for THC, but when they do studies, patients that use the NAC, the N-acetylcysteine, they use less pot. The dosing is, I believe, if I'm not mistaken, 2,400. It can be up to 2,400. And symptoms or like side effects of the NAC that I've heard from people over time or from the adolescents, it's not a common complaint, but it's constipation. That's really the only complaint that I hear from patients. Otherwise, it's tolerated. And they don't have to stay on it for a long time. It's a matter of helping them get off the THC as they get on the NAC and then revisiting this in a few months to see. The NAC also can help with anxiety or skin picking also. So it has other benefits too.
Let's see, we have another question. Forgive me if this was addressed, but when parents come to providers with concerns, would you counsel to maintain a non-judgmental approach to talk with their kids to maintain a rapport of trust and compassion with their teens?
Yeah. And so that is what I talk about with parents is we need to cultivate a relationship where your child is going to call you no matter what, and that there is no shame that comes up or self-blame. And that is crucial. That makes a difference between somebody calling you, and that's, to me, a life or death. Because if they feel like they can't call you, then they're in trouble. And so just what you're saying, that rapport and trust and compassion and non-judgment, a lot of times it depends on the teenager's backgrounds, because if the parent struggled with adolescent use, with use during adolescence and adults, they can share that story with their kid in order to show them hope, in order to show them that it can be overcome. And the parent might say, I didn't talk to you about it because, I'm sober and I'm good, but I want you to know that I've struggled too. So normalizing it too. So there is no judgment, there is no shunning. If we don't talk about it and we're not open, then it closes the door for communication.
Thank you. Can you talk a little bit about the consent related to substance use diagnosis and treatment with teens?
Yeah, so this one is tricky because the teen does not have to disclose the substance use to the parent. That's the teen's choice, the adolescent's choice. So that gets tricky because then when they need treatment, the teen has to agree to it. They have to agree to the releasing the consent to telling that to the parents. The teen doesn't have to tell that to the parents, which is tricky because the insurance goes through the parents. The parents have to approve the treatment. The way I look at it is the spirit of it is to encourage the adolescents to open up and talk about it. And so that's why for me, when we're doing about the craft and the questionnaire, that it's important to set the stage, set the frame, or frame it to the adolescent saying, this is to support you. This is to help you. Here are the steps that we're doing. And then to engage them and say, okay, at what point do we tell your parents? At what point do we ask for their help? And that's tricky.
When would you suggest utilizing residential services for an adolescent, and which programs do you recommend?
That's a great question. Something I've not talked about, there's something called ASAM criteria. And also that is a different way of stratifying the use. But if you remember that picture that I showed you with high risk use and then different levels of mild, moderate, or severe, and then actual addiction, when the child is in that moderate to severe level, I would start considering residential, but they have to have failed initial outpatient. So sort of the order of things is they're seeing primary care. We suspect there's some substance use. Now it's in the mild range. We do intervention, the behavior changes, then there's no bad outcome. There's no impact. That stays in the mild. Let's just say they come back and now it's becoming moderate, right? It increased. There's 5 or 6 sort of impacts with them. That puts it in the moderate. In the moderate level, you would do outpatient. So outpatient therapy with an addiction counselor would be like once a week or so, and then with parents intervention, that's still in the moderate range. If there is no improvement and they're progressing and they're still using and more impact, then that puts it in the severe. And at that level, they failed outpatient and now it has to be residential level of care. And that's when you would refer them. Programs, I'm familiar with the Abbey Center in the eastern side of Iowa and Cedar Rapids, I believe. But the Abbey Center is outpatient. So more outpatient, like intensive outpatient, partial program kind of intervention. Then there's also the Rosecrans-Jackson program. That is on my side of the state, on the western side of Iowa. They have residential program. These are 2 that come up to my mind too. Oh yes, somebody mentioned the YSS and the CFR in Iowa. These are other residential programs, yeah. And somebody else mentioned the Orchard Place. Thank you guys for outpatient and inpatient in Des Moines.
All right, thank you. We'll try to maybe cover one more. Any thoughts on best practices when working with adolescents with lower motivation? You had some really great suggestions, but just anything that you'd want to add about motivation?
I would really assess where they're at with their life. What's the most important thing for them? Is it friends that are most important thing? Is it sports that's most important thing? And that's what I would work for, is what gives them the most meaning and purpose. And then from there, I would engage the level of change. Sometimes they might not be motivated, and that's okay. And that's where I go back to you keep engaging with the relationship. You keep engaging and asking other questions about friendships, grades, what's important to them. You keep planting the seeds. Because at the age of 13 and 14, they might not ready to change, but at 16 and 17, they may be. This is not a one-time shot. I'm going to fix everything in that visit or 2 or even 1 year.
Okay.
But yeah, just one more thing. But also having said that, it depends because if there's legal involvement, then they would have to get engaged. They're forced to. They want to finish the probation if they want to finish the parole. And sometimes you're looking at a level where like you might be going to residential, and that motivates them because they don't want to go to residential. So also the context that they're into.
Yeah, another question was how do you deal with situations where the parents may not be on the same page, like with residential?
That's tricky because at what point is this something where they're neglecting to provide the care for the patient? And if that's a concern, then at what point is it we're having to tell them you're not providing the care, that's neglect. I don't want to have to talk to DHS, but that's getting to that level of care too. But also engaging with the parents around their questions. Are they in denial about the child using substances? Are they not seeing the impact of what's going on with the child? So I would engage with the parents one-on-one and the barriers and the roadblocks within themselves also, because a lot of times the parents are in denial about the substance use.
Okay. Well, thank you. So we have reached 1 o'clock. So I'll end with a couple of announcements before we close. The University of Iowa Carver College of Medicine is jointly accredited to provide continuing education for physicians, nurses, social workers, and physician associates, and all their participants will receive a certificate of participation. Attendees are eligible to claim continuing education credit by completing the evaluation and downloading their certificate of participation. I did attach that to the chat. However, I'll also send the instructions in the follow-up email. If you have any questions, please reach out to me at kafi-dixon@uiowa.edu. And I just want to thank you, Dr. Abu Ata, for a wonderful presentation. It's very informative. And thank you, everyone, for attending today. Have a great afternoon.
Thank you.
Bye. Thank you.
Okay. I think I stopped sharing, right? It's offline.
Yeah. Let me make
Yeah.
sure.